Hello and welcome everybody to today's Raising the Bar discussion about how organizations need to examine and transform workplace practices and policies to support and advance equity. I'm Dr. Karen DeSalvo. I'm the co-convener of the National Alliance to Impact the Social Determinants of Health and currently the Chief Health Officer at Google. NASDO, with support from the Robert Wood Johnson Foundation, has led the Raising the Bar project, including the development of its actionable framework to embed equity throughout healthcare organizations. Why now? Recent events like the COVID-19 pandemic and racial reckoning moved long-standing structural and systemic bias and racism to the forefront in the public's consciousness. Healthcare organizations have an imperative to confront the root causes of health inequities, to recognize that the current system is not effective in improving health and well-being for everyone, and repair the healthcare system itself. In this process, we heard a groundswell of support for equity efforts by all healthcare stakeholders in the development of the project, including for those who purchase, pay for, and deliver care. Adopting the Raising the Bar framework and committing to concrete actions provides healthcare a path forward. I'm so looking forward to today's discussion with our experts about one of the key roles healthcare organizations can play when it comes to equity, their employer role. We know that when workforce and leadership reflect the diversity of the communities they serve, care delivery and health outcomes are improved. As employers, healthcare organizations should model practices that allow all their workers to thrive and see opportunities to advance in the organization. What actions can employers take in service of advancing equity? Raising the Bar highlights these specific actions that employers can take, and our panel today will touch on many of these and more. Before I introduce them, I'd like to welcome Andrea Dukas from the Robert Wood Johnson Foundation, who will share some comments.
Thank you so much for that introduction, Karen. And thank you so much to everyone for joining us today. I'm taking a look at the chat. What a great group of participants from all over the country. It's thrilling to see you all here. It has been both an honor and a pleasure at the Robert Wood Johnson Foundation to be part of Raising the Bar since its inception back in 2020. And as Karen mentioned, recent events, most especially the COVID-19 pandemic, I think have made it very clear why a focus on health equity is so important at every level of healthcare organizations. What I love most and appreciate most about the Raising the Bar framework is that it represents a true 360-degree perspective about what healthcare organizations can be doing with respect to health equity. As a senior program officer at the Robert Wood Johnson Foundation, I hear from healthcare organizations, representatives at all different organizations, insurers, hospitals, health systems, you name it, who reach out to us pretty regularly to ask, what can we be doing to actually be meaningfully approaching health equity? Those questions are and a large part of what prompted our investment in Raising the Bar, to be able to provide a pretty robust response that reflects not only what a health system can do as a provider of care and a community partner, but also as an advocate. And with respect to this webinar, also as an employer. We hope that folks after this conversation will go onto the website, rtbhealthcare.org, and take a look at the fuller report, at the number of roles that NASDO and its partners have spelled out that healthcare organizations can play, and the concrete actions that they can impart as part of their organizations, along with case studies of how different organizations are already imbuing some of the roles and the actions that the Raising the Bar framework represents. So today's conversation and why you are all here is to talk about the specific actions employers can be taking to employ and support a diverse workforce. I really am looking forward to hearing from our panelists on these topics. They are stellar people. We are in for a treat today. So I'm going to stop taking up space in this conversation and turn it back over to you, Karen.
Great. Thank you so much, Andrea. I'm so excited to have the chance to introduce our panelists. What we're going to do is I'll introduce them in turn, ask them a question, they'll respond. We'll all come together. We've got some questions about culture, people, policies, and I do hope that you guys will drop questions in the chat if you have things that you want to raise with them, because we'll have some time at the end for that to happen as well. I'm going to start with Dr. Adia Harvey Wingfield, who's the Mary Tilston Hemingway Professor of Arts and Sciences, at Washington University in St. Louis. She's also the Vice Dean for Faculty Development and Diversity and co-director of the Public Scholarship Initiative. Her research has focused on racial and gender inequality in professional occupations, and she writes frequently for mainstream publications, including Slate, The Atlantic, Vox, and Harvard Business Review. All right, Adia, in your book, Flatlining, Race, Work, and Healthcare in the New Economy, you write about how hospitals, clinics, and other institutions participate in racial outsourcing, relying heavily on Black doctors, nurses, technicians, and physician assistants to do equity work, extra labor that makes organizations and their services more accessible to communities of color. Yet these Black workers often do this labor without recognition, compensation, or support. Tell us about this disconnect in healthcare and what needs to change.
Great. Well, first, thank you for having me, and please forgive my a little bit of hoarseness today. But I'm excited to talk a little bit more about this work. What I find, as you mentioned, is that in many organizational spaces, the verbal commitment to wanting more diversity doesn't always extend to actually implementing the resources that would support really achieving those goals. What ends up happening as a result is that Black healthcare workers in these institutions who are already underrepresented take on the additional labor of trying to make these spaces more palatable, more available to communities of color, and that varies depending on which workers we're talking about. So that doctors' efforts may look different from nurses' efforts may look different from technicians, and so forth. What I argue in the book, though, is that when we think about how that equity work exists and how that mismatch between racial outsourcing and equity work occurs, there are pretty dire and severe consequences for that. It means that Black workers are more likely to feel alienated, they're more likely to feel burned out, they are more likely to feel exploited by the organizations where they work and distanced from their coworkers, often because they find themselves in the position of doing this additional labor and this extra work. So we might find that Black doctors, for example, are very attuned to trying to engage in mentoring initiatives to try to make sure that they are addressing the ways that Black workers and Black doctors in particular can often be left out of those integral structures and networks that allow for really flourishing in the profession. Nurses may find that they don't necessarily believe they have the same opportunities and visibility as doctors, so they instead visualize themselves as change agents and think about how they can try to change organizational structures and think about how they can really commit to and fight for better equity and better opportunities for their patients. So what I think the key takeaway here is that for people who are in leadership roles in these organizations, a lot of the mismatch occurs because Black healthcare workers are doing this work usually isolated by themselves, without resources, without support, and they are doing so on top of an already very taxing and demanding job that requires a lot of time and energy and attention. And that's part of what gives rise to the burnout and the feelings of alienation. I suggest that many organizational structures think about how these issues can move, or these initiatives can move from being individually driven ones to organizational level ones. So what happens when organizations actually formalize and institutionalize mentoring programs where people who are interested in the physician profession have access to somebody who can give them training, guidance, support in moving in the field? Research has shown us that institutionalizing formalized mentoring programs actually helps to work. It makes a difference and it moves the needle. What happens when we have cross-level diversity committees where people from a variety of different levels in the organization are focused on improving and addressing diversity? Again, research shows that actually yields concrete, tangible results and helps to make people from all levels of the organization more attuned to where and how they can be better focused on improving diversity and changing these outcomes. So I really want to stress and emphasize that many of the things that I think organizations can be doing stem from things that are already happening in practice within organizational spaces. They just happen from people who are already, as I mentioned, individuals who are doing this work on top of the existing labor that they have, but that these solutions should be organizationally driven ones and more systemic rather than individually driven ones where one or two people are trying to actually realize these changes in these outcomes.
I think that's the fantastic way to think about it, this systemness, but the institutionalization. And it's a really good segue into talking to Alan. Alan Neville is the Senior Vice President and Chief Equity Officer for the Metro Health System in Cleveland, Ohio, that has more than 7,800 employees. In his uniquely integrated leadership role, Alan's responsible for defining the overarching vision, identity, and strategy to ensure that equity is the underlying central principle in all that the system does. Alan and his team's primary focus is to work across the administration, all of Metro Health's departments and programs and initiatives to eliminate systemic disparities and inequities that impact the patients, but also employees and the community that they serve. Alan, a year ago, Metro Health named you as its first Chief Equity Officer, a position that's becoming more common at hospitals, health systems, at insurers, and other healthcare organizations across the country. Can you share more about what your purview is and why you think it's important that these kinds of positions exist?
Certainly. It is a privilege and a pleasure to be here with you this afternoon. I joined Metro Health in 2018 as Chief Diversity and Human Resources Officer. And at that point in time, obviously pre-COVID, we were very intentional in having human resources report directly into diversity, because from an employee perspective, it's very easy to see that many of our HR policies, programs, and systems create natural micro advantages for some and micro inequities for others. And typically those micro inequities impact people of color who in most organizations tend to be at the lower portion of the pyramid. We don't tend to see a lot of folks who look like me at the senior most levels in organizations. And that's really no different from other industries. It's not just a healthcare specific issue. But what we realized after the murder of George Floyd and the onslaught of COVID, and understanding how disproportionately impacted underrepresented minorities were based on this dreadful illness, the fact that more people were on ventilators, percentage-wise, more people were hospitalized, all of those things, we realized that it was really time for us to change the trajectory of our organization, which we always considered ourselves just based on the fact that we're a public healthcare institution. We take care of those who don't have an ability to pay or are on Medicare, Medicaid, or underinsured. So over 70% of our folks are either on Medicare, Medicaid, uninsured, or underinsured. So they tend to be people who come from underrepresented communities. But all that being said, we realized that we had an opportunity to really change the trajectory of our work. And that's what resulted in creating an Office of Equity. What I think is a little bit unique about my role is that it's not just health equity. Now, we realize that there are a number of historical disparities that impact communities of color. We know about things like Tuskegee, the story of Henrietta Lacks, what we've seen with COVID, the maternal and fetal mortality rates that are staggering in Black and Brown communities. But we also realize that we can't just look at it just through the lens of health equity. We need to look at it as equity for all. So all of our patients, our employees, and those folks in the community. When we think about our employees, 95% of our employees are our patients as well. And I shouldn't have to walk into one of our facilities wearing my badge in order to get treated with dignity and respect versus going in with my normal weekend attire, which would be probably a baseball cap, a hooded sweatshirt, and perhaps some sneakers or some boots. So we realized that we have to, as Ada had mentioned, we have to really look internally to our organizations in order to successfully impact our patients and our community, and really listen with empathy, which means listening with not only the head, but also the heart.
It's really exciting endeavor that you're on, and I very much appreciate you framing this as equity as a core principle for what the system does, that it's more than about the healthcare outcomes, but your sort of way being, and we'll have a chance to talk a bit about culture when we bring everybody into the conversation. But I'm going to ask Denise Octavia Smith to join us. She's the founding executive director of the National Association of Community Health Workers, which is a nonprofit whose mission is to unify community health workers across geography, ethnicity, sector, and experience to support communities to achieve health, equity, and social justice. During the COVID-19 pandemic, Denise co-founded the Community-Based Workforce Alliance and the Vaccine Equity Cooperative to develop and advocate for national initiatives that will advance community health worker leadership and community capacity in COVID-19 response and community recovery, pursue racial equity, and improve clinical and community integration to address the social drivers of well-being. So, a person after my own heart. Community health workers are known for sharing life experience, trust, and often cultural alignment with the communities where they live and serve. The COVID-19 pandemic highlighted and continues to highlight just how important this is. So, Denise, can you speak about some specific examples of how having a healthcare workforce that reflects the community improves care, experience, and health outcomes during the COVID-19 pandemic and more generally?
Yeah, thank you so much, Karen, for having me. And it's amazing to see so many people joining the webinar today. So I'm really excited to get into the chat as well. Listening to Ida, Adia, and Alan in their comments, it actually made me also be reflective of history. And something that I often think about is the Heckler Report of 1985. That report, which eventually was the fuel to develop the Office of Minority Health. And in that report, there was a very specific call while coming to the end of the result, which was the identification of glaring disparity for Black and minority populations in the US, which was a call for an assault on these health disparities. And I often reflect on that very specific language because 40 years since that time, we had what was a persistent structural inequities and historic racism upon which this perfect storm of the pandemic was able to wreak disproportionate havoc in communities of color. And I want to also lift up tribal communities because I don't know if we will have representation or time to really unpack the further inequity of having to navigate not only federal interactions and communications, but also those at the state level as it concerned getting PPE, access to the vaccine, or access to care. What's important about this assault is that those who care most deeply, those in fact who are most impacted, should be closest to developing the solutions, right? That phrase has been used for quite some time and is at the heart of every social movement. Community health workers, however, while our national identity is that we are persons with lived experience, survivors of cancer, persons living with HIV, persons who have experienced homelessness, as I have, persons who have survived a rare chronic disease, as I have, right? We are often, as Alan said, not only the lowest paid among all of the public health professionals, but often we are considered as some sort of downstream actor who is not considered as a leader or even a member of the team to design and develop interventions that will transform the way services are delivered, the way systems are built, right? And the way that policies have, I would say, multi-generational impact. So 2 quick examples. I mean, the first is really very personal. I was diagnosed with a rare chronic disease in 2005. And for 7 or 8 years, I was in the emergency room, 5 to maybe 8 times every year. For me to traverse all of the siloed services, I will say, just for summary's sake, and to eventually come to survivorship, I received the services of a community health worker and a patient navigator, even though I was a CHW. So navigating the legal ramifications, accessing healthcare, understanding my disease state, addressing all of the costs, and all of the other more human elements and aspects to bring me to survivorship required the support beyond that which my husband or caregiver or mother could provide. It required someone who could help me navigate those services. But just last week, I was in South Carolina at the South Carolina CHW Association conference, and I met a young man, 28 years old, a young man who is living with HIV, a young man who is non-conforming in terms of a side gender experience, and a person who had experienced homelessness. And he spoke about being available 24 hours a day, right? Rolling out of bed in the middle of the night to go and help another youth who had experienced homelessness, another youth who had been kicked out of their home, to make sure that they could receive their medications and get a hot meal and have a place to lay their head. This is the benefit of having someone with lived experience, because beyond the profession, which I think we'll talk about, beyond the competency and skill and qualities, you have the human element of having lived that experience. That brings an extra layer, I think, of compassion and commitment to make sure that people have a chance to achieve health and well-being.
Denise, that's a great story, and I love that it's so fresh. Had an opportunity to build out community health workers as a part of our community health centers in the New Orleans area, and found that the trust factor that you're describing, it comes some from lived experience, shared lived experience. I think also from beautiful humility that CHWs can bring to the table to really open up their hearts and minds and welcome people into the healthcare ecosystem. So I think I love the story you're describing of literally this young person being ready and willing to be open and trusted literally 24 hours a day, 7 days a week. It's tough work. Okay, so we're going to jump into a set of questions that kind of generally fall into people and policies and culture, and maybe just sort of starting with this idea that you had of systematizing and institutionalizing equity. It really requires leadership buy-in, I think. And so I'd love for you to start and others to step in to talk about how we build leaders who understand and will have that lens of equity, build that into their policies, recognizing their responsibilities as gatekeepers, but not only so how we build them, but also the ones that are in the seat, how can we help them understand?
Yeah, that's a great question. I mean, I think we just have to be very candid. The types of changes that we're talking about, they don't happen without leadership support. You cannot fundamentally and comprehensively change an organization or an institution if leadership does not share that vision and that they are not equally and fully committed to making these types of changes. At the same time, we also know from the research that having leadership focused on and committed to making these changes has clear implications for what's going to happen in terms of the extent and level of buy-in from others in the organization. This is part of the reason why I mentioned how important it is and how research has documented that one of the key changes that we do see in making organizational change is actually implementing diversity task forces that can work in conjunction with someone who is in the role of being the diversity VP or manager or so forth. Part of why those task forces are so successful is because if done correctly, they pull from people at multiple levels of the organization, so that it's not just people who are at the top or people who are in the middle. People from various levels of the organizational structure are reflected, and they are working together on this common goal and this common task. That way, people from across the organization can bring in their views and their experiences and be prepared to address challenges that may emerge in the organizational structure. But it actually makes people responsible for creating these solutions and addressing these issues, so that it isn't just one person's job, whether that person is formally institutionalized in an official role or not. It becomes everybody's responsibility. It becomes everybody's goal. It becomes everybody's focal point, at least for the purposes of that particular committee. So that's an outcome that we can see when leadership is focused on that particular goal. And the only other thing that I'll add, when you talk about how we get people to see this as being important and to see this as critical and necessary, one of the things that I always come back to is that if we think about where this country is going, it's absolutely fundamental for us to be focused on these issues of diversity and equity and inclusion. Our demographics are changing in the United States. Our population is changing in the United States. So we're really at a critical juncture here, I think, in terms of thinking about where we're going to be and what kind of country we're going to be. Are we going to be a country where an increasing majority of our citizens are people who are disproportionately locked out of influential, high-ranking, high-status positions, and where we continue to see such ongoing social stratification along racial lines? Or are we going to be a society where we finally take this opportunity to address these systemic barriers so that everybody has opportunities and everybody's experiences and outcomes and perspectives are fully included and brought into the central functioning of how organizations operate? And that doesn't mean hiring one or two people who are underrepresented and saying, okay, job's done. We brought in our 2 or 3 people. That really means thinking very comprehensively and critically about how organizations have to change, how culture has to change, and what it means to say that we want to be more diverse, representative, and inclusive places, because that often means that organizations can't function the way that they have. But I think that also sets many organizations on a path for being places that are better equipped for a 21st century that is going to become increasingly diverse, increasingly multiracial, and increasingly different than the organizations and the society that we've had in the past.
And representative more of the communities that healthcare is serving, that frankly anyone is serving, because the country and the world are really changing. Alan, maybe you could talk a bit about some of the ways that you all have been working on building that more diverse workforce that Adia is talking about, who are going to meet those needs of people in the community, but also be able to do that in a way that allows them to be successful all across the career ladder in healthcare organizations.
Certainly, I think Adia raised some great points. In terms of, I think we really have to look at this at its most common element, which is our shared humanity. And when you strip away what you see or what you think you see, at the end of the day, we're all made up of flesh, blood, bone, and a lot of water. So the issues that have gotten us to this point, in my opinion, is because we haven't looked at things as a shared human experience. Whatever happens to me, it does impact you. Poverty impacts those who are wealthy. The fact of being unhealthy, having the healthcare disparities that we're talking about, they impact entire communities. So there's a shared level of accountability and ownership. And one thing that Adia mentioned is you have to have representation within your organization across all levels. We started at the top of the house. We started with our board. Both our system and our foundation board went through an immersive educational experience where we literally ripped the Band-Aid off of what's traditionally viewed as diversity, equity, and inclusion. We went directly to racism. And we shared some very graphic images, not to cause anyone to feel as though they were responsible for what happened to Emmett Till or others. But there is a responsibility to change the narrative going forward for our children and our children's children and so forth. So we started there. In terms of tactical things that we've done, we're home, to our knowledge, of the only high school located within a hospital in the United States. It's the Lincoln West School of Science and Health, which is made up of predominantly Black and brown children representing 9 countries speaking 7 different languages. These are students who are or have been homeless, to Denise's earlier point. These are students who at the age of 14, 15 years old are heads of household. We have 363 participants. Be very interesting to see how many have had to be a head of household at 14, 15 years old, where you go to school during the day, but you also have to be a breadwinner for the rest of the family. Yet we've been able to maintain a 95% graduation rate, which is actually a misnomer. It's a partnership with the Cleveland Metropolitan School District. It's a 95% graduation rate based off of our graduation date, which is the 3rd Friday in June. But it is a year-round school. And if you think about what's transpired over the last couple of years, anybody who's on this call right now, who's a parent, grandparent, aunt, uncle, caregiver, mentor to someone young, saw that child in school one week, out of school the next, hybrid the next. So in terms of resiliency, our youth are far more resilient, in my opinion, than any of us, based on what they've had to go through over the last couple of years. But if we look at when the kids do graduate, it's actually over 98.7%, because some of our students have had to wait an extra month or 2 in order to graduate. But we look at this in terms of raising their economic stature early on. So we offer programs such as state-tested nursing assistants, so CNAs, some people may call them that. We also have dental assistant programs for those high schoolers where they can actually get their certification upon graduation and actually find gainful employment. And then we also have a lot of money that we spend in terms of tuition reimbursement. So those kids who don't want to go directly to school can earn a decent wage and get school paid for on our nickel. The other thing is the vast majority of our students, when they graduate, they end up going to school either for free or nearly for free through our partnership with Say Yes to Education and College Now. So we've got a number of programs to begin building that pipeline of the next generation of talent, because we know, to Adia's point, our demographics across this country are changing. So we have to make sure that there's representation in those areas. And ultimately, my last point will be this. In my opinion, for far too long, many of us as healthcare practitioners have viewed this as we're going to fix those people. Well, first off, those people look just like us, number one. Number two, they don't want you to fix them. They want you to sit down with them and let's co-develop these solutions. I want to be involved in my own health plan. I want to have skin in the game, just like my provider and that entire team that's taking care of me. So to my earlier point around empathetic listening, I think all of this boils down to my synopsis of Maslow's hierarchy of needs. People want to feel safe. Our patients want to feel safe. When they interact with the provider, they want to know that that provider is culturally competent, that knows that if I'm a African-American female with a history of fibroids, not only myself, but also other women in my family, and now I'm pregnant, you need to keep an eye on me. You need to ask some questions that you might not ask my white counterparts. From an employee perspective, employees want to feel psychologically safe, that when they see or hear something that's not quite right, they can speak out without fear of retaliation or retribution. So we want to feel safe, but we also want to be heard, not just heard, but understood. If you're not sure, ask questions. I think we need to do that more with our patients, to ask those questions. And if I happen to be a multilingual, multicultural provider, that may take even longer during that visit. So I think we have to really look at how we pay for performance with our providers, because to that first question you asked, sometimes you do have to take a little bit longer in order to get that translation, even if you're both speaking English. You have to build that trust. The last thing is, all of our patients want to feel helped and our employees want to feel valued.
I think that it's beautifully said, and there's a element of what you're describing about sharing power in a meaningful way across the organization, as well as with the patients and the community. In the Raising the Bar document talks, we heard a lot about that throughout the various conversations. It's critically important, and in fact, maybe Denise, you could just say a word about the experience of community health workers speaking truth to power when they join organizations who maybe haven't had the same lived experiences, or maybe similar, but haven't thought about it in the context of healthcare, and ways that the conversations and the policies and practices in healthcare are enriched and enhanced by having a more not only diverse workforce based on race and ethnicity and lived experience, but also professional background.
Yeah, there's a lot there. I just appreciate this discussion, in particular, what it means to have a champion within the organization, and what happens when an organization does not have genuine leadership, both in title, but also in passion to sort of drive this. You know, and you think about what motivates people to do anything, right? They do things because it protects them. They do things because it benefits them. They do things to get accolades from their peers, right? Or they do things maybe because it's the right thing to do, you know? And I think what we all hope is that we can both cultivate and also identify existing leadership that is able to create an environment where this is truly the right thing to do. You know, I've been a CHW for about 24 years now, and I've had the great pleasure, because most of my life was spent providing services for people living with HIV. that I had the chance to work with an LPN, an APRN, a social worker, and a primary care doc who really got it, right? I was a part of the care team. And that was a very unique experience I found later from my other peers, right? Sort of saying, oh yeah, I'm headed to the, to my meeting, my case meeting. And they were like, yeah, okay. I get a stack of flyers, and I'm told to distribute these flyers. So it was an awakening. And I just want to say there's so much that we could learn from the HIV community and from those models. I just want to honor also that history and respect. We've had for the last 20 or so years a definition of who CHWs are, largely cultivated within the American Public Health Association, and lots of folks know that definition. I think NACHWA, as a member organization of CHWs, we take that a step further and really talk about the fact that we are people who are predominantly female. We are persons of color, not exclusively female, but predominantly. We share the ethnicity, the diagnosis, the socioeconomic status, the geography, right, with the marginalized communities where we live and serve. And I say we live and serve. We're not, helicoptering in and then going out. We live and serve in those communities. We are disproportionately affected by these inequities. And so oftentimes we're experiencing the same barriers, not only to health and healthcare, which is often what I say, but also to academic achievement, right? Being able to afford college, right? Having the opportunity. There are some CHWs today who are struggling with the cost of membership in a state association, okay? Our association membership is $20. And there are promotores who contact me year round and say, $20 is a lot. And I sort of didn't believe that until I went to El Paso 3 weeks ago and sat in a promotora conference and heard that these women were getting paid $7 or $9 an hour to do the same work that here in Connecticut, we might get paid $30 for. Okay, so the inequity is really deep-seated, and it does have its professional bias. The lack of a national professional identity for community health workers. In other words, who are we? What do we do? Where are we? Why do we do it? And how are we unique from case managers and social workers and nurses? And how are we unique? That conversation still really needs to be cultivated, I think, in our local or statewide systems. But I think what's important is that people understand that lived experience is expertise. Mm-hmm. Okay, so professional hierarchies serve academic institutions. I know, I worked in one, I'm very familiar with them. They serve us in traditional ways. But if the goal is to ensure that all people have the opportunity to achieve their highest health and well-being, right? If our mission statement talks about racial and health equity, we cannot keep our budgets the way they are, where the promotoras are paid $9 an hour and the CEO is paid $400,000 or more. I've never been a CEO of a large organization, so I may be underrepresenting that number. We can't have the pyramid. We know this from all other budgets, except when it comes to our budget, it becomes a challenge. So there are specific ways that NACHWA, we invite you to go to our website so you can understand, how do I recruit and interview a person who doesn't have a bachelor's or master's degree, but still identify the requirements for the position, right? How do I assess? And how do I help my HR departments write those job descriptions so that I can identify a person who will be trusted with cultural and linguistic alignment, right, have the lived experience, and still be able to be a competent and high quality part of the care team?
I say trusted and respected. And some of what you all have gotten to is the necessity of having a culture that respects and is not just about DEI, but also about true belonging, that is looking at this comprehensive workforce and is inclusive of patients and community. This is a tall order, and You know, I went to medical school a long time ago, but we were not trained in that way. We were trained very much to be independent and have a very hierarchical structure. So I think we're at this really important time of beginning to shift the way leaders and people who have been in the industry longer begin to understand, respect, and think differently about the problems that we're here to solve. So we have about 6 minutes for this, and I promise you all I have 2 more questions I want to ask. So let's do a quick round robin about secrets to culture. Alan, I hope you'll talk about the dermatology work that you all are doing to do some institutionalization.
Yeah, so one of the things that we've done, I talked about ensuring that we have culturally competent providers. So what we've done is we've recently launched our multicultural healthcare centers of excellence across multiple subspecialties. So our first one is in dermatology. And what's very interesting about this is not just a marketing ploy to get more Black and brown people into our locations. This is really around ensuring that we ask the right questions, we're giving the proper care, and that we have the right resources, the right tools. There are certain pieces of equipment that we found out from our chair of dermatology. He said, hey, if I had this, I could probably be a better provider to our Black and brown patients. So what we've done within our office is we've basically become the middle person, if you will, in order to ensure that we acquire those types of tools and resources. Along the way, there's plenty of education for that chair's staff. So it's not just take one class, you've checked the box and you're good to go. How do we ensure that we do reinforcement? How do we ensure that we're reading articles, the latest trends, latest changes as they relate to skin and hair of color? So we've really looked at it end to end in order to ensure that we're doing this across the entire continuum. Like many public healthcare institutions, the vast majority of our patients come in through the ED. So how do we change that narrative to where they have a primary care provider and whatever specialists that they need in order to ensure that we make them healthier rather than just taking care of them if they're sick? How do we ensure that they're able to live their best lives and be healthy? Because that's what's going to impact our community, and really that rising tide lifts all boats mentality. And we look at that across those social determinants or social drivers of health. That's why we're involved in housing development, education, all of those. We establish partnerships with a number of organizations in order to really change that trajectory for folks.
Any other comments about culture?
As far as culture,
I'm sorry, Alan, I'm gonna pitch it to Denise and Adia. Go. Oh, did we lose you?
Sorry, I thought Denise was going to go ahead. Yeah, I would just echo that. I think it's important when we think about culture to link that to organizational mission as well. And this is where I think healthcare has a really unique role, because unlike some other industries that I won't name, healthcare is focused on the greater good. I found that most people that go into healthcare that I've spoken with, they go into it because they genuinely want to provide healthcare. They want to improve outcomes. They want to improve health. They want to be focused on the way that they can have a tangible impact on making people's lives better and improving quality of life in that particular way. So I think when we think about how to change and restructure culture in these organizations, I think healthcare is one of the industries that has more opportunities, in the sense that there is a clear link between what I think many people come to the healthcare industry to do and shifting the culture in a way that makes that outcome more realizable and more tangible. So I think connecting those things really has I think there's a clear opportunity to connect those things in healthcare in ways that may not be present in other spaces, because people do seem to be motivated by wanting to see how they can be helpful and what they can do to provide better care for people. It just means thinking differently in some ways about which people we're reaching and what that requires of people in an organization.
That's great. Anything to add, Denise?
I mean, a lot of things are running through my brain. You know, I was sitting here thinking about the class standards, if anyone can remember them. And I say that sort of tongue in cheek, only because this was sort of a completely unfunded mandate that I think had a lot of hyper practical strategies that organizations could use, but no one really had any requirement to do that. And so I often wonder, you know, how federal dollars flow the way that they do, but yet we don't make any demands or requirements upon these dollars to ensure that they're getting to folks who need them most. It's very painful, to go to a statewide meeting and hear that practitioners had to turn away people from behavioral health support groups because they didn't have anyone to do translation, right? Mm-hmm. And so you wonder, when are you going to collect the data, right? So that you can map that to the services that people need. So I think to a certain extent, again, when you don't have regulations or mandates, then you have to look to organizational leadership. The other thing, from a community perspective, and there may be folks here who are also thinking about that perspective as well, we have to do our due diligence to large organizations, large employers that are coming in or that are in our communities. I'm not going to mention any names, but here in the state of Connecticut, we have a serious war going on of about 3 major organizations that are gobbling up all smaller hospitals, urgent cares, primary care spaces. And, and one of the results is that they are shutting down services, right? When I was in South Carolina, it was very common for the women there who are doulas to say, you have to drive 40 or 50 miles if you want to deliver your baby. I mean, I just don't know how much longer we are going to allow that to take place. So if the culture is not changing from within, it behooves the community to put pressure on that institution, that organization. In particular, if many community members are your nurses, they're working in the cafeteria, they're orderlies, they're CNAs, they're working in the lab. If we have community members who are invested, we should have a voice. And what I loved about Raising the Bar and being a part of it is we started to think about all of the employees within the organization and why all of those employees do not have an opportunity, not just to weigh in, right, on the strategies, on the mission statement, et cetera, but to hold accountable the body, the organization. Right? It's not always about one person. We all know that we're interdependent, but that we as an organization have to say we're not really doing it well. And the last thing I want to say, the chat is just blowing up. And there was a person in the chat saying, I work at a small organization. There are about 15 people. What do I do? How do I identify one person to be the focus? And I just want to say, as a young executive director of 10 staff, we do that by holding the entire team accountable. It certainly happens in our hiring practice. We have a majority of community health workers. We're diverse in geography, ethnicity, gender, language, but that doesn't mean that I don't have bias, right? What that means is, and I'm the executive director, that means that I have to get with my team and we have to figure out how we can infuse our values across all of the work that we do. Right? And that includes accessibility of our website and our materials. And it also includes how we spend our dollars, right? So it's all of that. So I think for small organizations, it may even be easier because y'all can just huddle up and we're 100% virtual and we're trying to hold ourselves accountable.
Yeah, great. Well, you guys all mentioned accountability and I very much appreciate that. There's a little more in the report about it. We also didn't get a chance to talk about policies, which I think all of you kind of touched on a bit. It's more than just the healthcare. It's paid family sick leave. It's living wage. It's all of the other ways that as an employer, healthcare can really step up. It's local procurement. So those are anchor institution opportunities, and I just want to throw those out for folks. But I want to get to the questions from the audience. We have a couple teed up that are recommended for us, and so I'll just start with it and throw it out to all of you guys, whoever wants to start. Anything about diversity and equity is often pushed back on as critical race theory, a term that most don't even understand. How do you counter pushback and continue to do equity work without it becoming political?
I think within our organization, we've been blessed to not even talk about CRT, to be honest with you. It's my opinion that you can focus on the toxic 20%, or you can get the 60% in the middle to move in the direction that you want to. So for us, what we've done is we've created a psychologically safe environment to engage in dialogue. And I believe someone brought up the fact that we've got biases. Absolutely. But those biases are learned. You put 5 babies in a playpen of varying races, ethnicities, gender, and what do? They just play. They don't say, oh, your hair is different than mine. Your skin color is different than mine. So just like you learn all these biases, you can unlearn them. So that's what we've really been focused on. And we realize that everybody's going to be in a different place on that change curve, if you will. So it's a combination of education, exercising some grace. But what we try to focus on, and this was said a little bit earlier, we're here because of our mission, our vision, and our values. And we've had people leave our system, go elsewhere, and guess what? They come back. And they may come back even though the pay isn't as high as it was somewhere else. So that's what we really try to center on.
Anybody else want to jump in? I saw you taking yourself off mute.
Yeah, I just would add that this is why part of why leadership is so important, because that makes a big difference in whether there's the commitment and the focus in the way that Alan is talking about versus the ability to misrepresent and mischaracterize this type of work in ways that respond to political buzzwords.
Yeah, and we know that those folks will leave. If they don't like it, they'll leave. And some attrition is okay.
I think we're in a really exciting time in healthcare, as you guys all mentioned, because it seems to have become increasingly part of mission statements, including strong statements about creating anti-racist institutions. So a lot of opportunity here, I think, for this to be a movement and to be successful, which is the next question we have. And it's thanks to someone for asking about measuring impact. It's related to accountability, but maybe a little more specific is we'd like to measure impact on experiences of workplace discrimination in a pilot program, but don't know of existing metrics. Do panelists have suggestions? You may have stumped the panel. Maybe short of specific. Oh, go ahead, Adia. Were you going to say something?
Well, I wasn't sure I completely understood the question.
Okay.
Is there a lack of knowing which metrics to focus on? Is that what that person is asking?
Yeah,
or maybe
I'll
if you
read
could
it
read it again, that might be helpful.
Yeah, I will. We'd like to measure impact on experiences of workplace discrimination in a pilot program, but don't know of existing metrics. Do panelists have any suggestions?
So what we did in our organization, a little bit different from that. I think there's this, I'm right-brained, so you're going to get a right-brained answer to this, just so you know. The way that we've done it is it's been experiential. So for us, it's about patient outcomes at the end of the day. But from an employee perspective, we created a listening series. It's called Healing Begins with Listening, where we have 1.5-minute video segments. And I invite you to go out to metrohealth.org and type in Healing Begins with Listening. You'll see a whole series of videos where our employees shared their experiences. One in particular, we had a gentleman who was part of our No One Dies Alone program. He went up to the room of a patient who was at end of life, volunteered to sit with that person while their family went to take a break. Because of the color of his skin, he was turned away. How many of us on our deathbed, particularly during COVID, where your family couldn't even come and see you, would have loved to be able to hold any person's hand? I don't care what they look like. I don't care what their gender was. Someone mentioned in here about having differing abilities. Just to be able to hold another human being's hand, that's why I talk about the fact that this is about our shared humanity. Any of us would have accepted that.
Thank you, Alan. Denise or Adia, anything on measurement?
Just that I think as a researcher, we deal with a variety of different measurement tools. I think that general survey data is useful, but I would suggest for a project like this to think also about qualitative approaches that allow you to get the voices of respondents in your healthcare institution, to get a sense from them about what particular things they may be experiencing that may not fit quite so neatly in the survey data. I think that would give a more robust finding.
Sounds like a
I think there's always fear when you're collecting this information of retaliation. I think it depends on the size of the organization, whether or not people feel that they are truly providing frank, open, and anonymous responses. I also just want to say that really just to eliminate the CRT discussions, and I know I've been in some of those discussions too. I had a health plan leader in Hawaii tell me that she couldn't go back to her team and use the word racism. And I thought, you live in Hawaii. I was like, do you not know the history of Hawaii? And I really just think the remedy to all of that is to tell stories. The United States is a very young country. And I think we are not, we have a strange relationship with history. And I think if people tell the stories of the place where they are, and if they don't know those stories, to find out those stories, they will eliminate some of the national discussion that is not always applicable to varying communities, but they will also zero in on that which is persistent, that which is historic, and that which is inequitable.
Great. Back to humanity. All right, round robin on the one piece of advice that you would give to members of the audience. Just one quick lightning round. We have 3 minutes and I have a few closing remarks.
Hire community health workers and pay them a thriving wage
Shocking.
to be a part of your integrated care team.
Adia?
That's a great one. I will just borrow from my research in this topic and say to think about making solutions structural and involving everybody.
Beautiful. And Alan?
I would say somebody put in there, amen, Denise. So I'm going to second that. But also, I think not just hire them, not just pay them, listen to them. You have to empower them because ultimately they're in the trenches. They know what's going on and they have the trust with the community, with the patient, and they can really be those gatekeepers for us to go in and build those trusting relationships as well.
Perfect. All right. Well, listen, I want to thank our expert speakers. What a great discussion. I learned a lot. I hope everybody else did. I thought you all brought such nice different perspectives to a really important challenge, perhaps the most important of our time in healthcare. I want to thank the Robert Wood Johnson Foundation for supporting the Raising the Bar project, as well as today's conversation. Thank you guys for all being here. I really hope you'll spend some time looking at the Raising the Bar resources, which has examples of what organizations are doing, like Alan, has input from people like those that are on in the conversations today, like Denise mentioned. And so you can learn more by visiting rtbhealthcare.org. And I just want to say thank you again, and I really hope you all enjoy the rest of your day, and I look forward to seeing this work blossom all across the country.